I'm Dr. Jam Kothari.
And I'm Dr. Sally Moore. And this is a Myeloma Minutes, a podcast for people affected by myeloma, patients, friends and family.
Hi Sal, good morning. How are you doing?
I'm good, Jam. I'm sat actually at the moment, I don't know if this is audible to our listeners, in some weird cubby hole with no lighting and everything echoing because I've moved back into my old house, which has been renovated. So yeah, I'm good. It's been a mental time, so busy. But yeah,
congratulations.
Life is good.
Moving house is well known to be a very unstressful experience.
Indeed, I've enjoyed every single minute of it.
Yeah, well, no, I'm glad it's happened, and it's good to be chatting to you again on this lovely sunny morning. Today's topic is something so central to a number of aspects of myeloma, unfortunately. That is pain. We're going to talk about pain in myeloma.
Yeah, definitely. I think this is an evolving area. It's something that we, I think, on the job have had to become skilled about, because it's interesting, isn't it? When you train as a doctor and at medical school, I don't remember getting many lectures or much education about pain. And I think so much of what we do is addressing how people are managing and coping with their lives and figuring out what their pain's about and what the right painkillers are. So there's a lot to delve into today, and it should hopefully be really, hopefully quite meaningful and interesting for our listeners.
Clearly, in many medical conditions, pain is central to the human experience, and the understanding of what we call acute pain, or pain that happens very often intensely and in the short term, is slightly different to so-called chronic pain that can last for longer periods of time. And there is a big psychological component to some aspects of pain as well. And all of these things are intricately involved in a number of aspects of myeloma, whether that be the actual impact of the disease causing pain, or sometimes effects of certain types of treatment causing different types of pain, such as neuropathy, which we have delved into in another podcast. But, Sal, we were talking about what we'd like to cover today, and in so many of our clinic appointments, talking about pain. Are you in pain? How do you feel it? Where do you feel it? What are you taking for it? Understanding the essence of why they're getting it and trying to make that better is something that's happening up and down the country in every myeloma clinic.
I couldn't agree more. And I think what's so important to remember about pain is when we are asking those questions in clinic, it's helping us figure out how the myeloma is behaving. But it's also trying to sort of explore how that person is getting on with living with their myeloma. Because let's not forget, when you have pain, and if you're living with pain day to day, it impacts on every single aspect of your life. Now, I can say this because I've got direct experience with a tiny bit of pain over the last week. Moving back into my house, I tripped over and I've broken my toe. And my goodness, it's having a little tiny break in your toe can stop you from doing X, Y, or Z. Now, that is almost irrelevant relative to some of the pain that people have to live with and cope with day after day after day. And I think we often not that we don't disregard it, but like I say, how it impacts on your sleep, on your socialization, on your appetite, on coping with the other medication. I mean, it's so wide-ranging, and your mental health, of course. So this is actually a hugely important area, which I always want to sort of upskill myself about so I can offer the best outcome for my patients. And I'm sure you're the same in that regard, Jam.
Totally. And with a condition like myeloma, that one of the main ways in which it impacts people is those significant effects on the skeleton. It's very conceptually, in a way, straightforward to understand why myeloma can be an extremely painful condition. And also, that's what really scares people as well. We're always talking about skeletal symptoms. Do you have pain in your spine or your pelvis or your arms? What that can mean from when people are being diagnosed. But also, Sally, all those people that, are in remission and then going through the points where actually they've just tweaked their back, picking up a box. It's like, is my myeloma coming back? And, people link any pain, which, is just part of life, to their myeloma coming back. And that's just an extra sort of psychological hurdle that, so many of our patients have to deal with.
Definitely. And I think, in an ideal world, what we'd like to see for all of our patients is they're diagnosed promptly, that they don't necessarily ever get bone disease. And if they do present with bone disease, the bones heal and they live a life that's pain-free. But I think what we do see in many of the patients we looked after is that trajectory is rarely that smooth. And even if their bone disease, for example, is healed and the pain from that broken bone, for example, has improved, they might then be suffering with discomfort, to say the least, or pain because of side effects of medication, which we also want to prevent and mitigate. So many, many, many layers to this. And actually, our patients and their carers are so important, clearly, in this conversation, to signpost us as a team to what matters most, to what, to try and address first.
So if we get to the bones and the skeleton, clearly fractures are incredibly painful, and they can be fractures, of course, in the spine or any other bone. And that can sometimes be the first sign that someone has multiple myeloma. But even if you don't get fractures, the development of those lesions, those areas in the bone, at the beginning, often they can be completely without symptoms, which in itself is something that we need to be aware of. And that's why, scans are so important. But as they get bigger, they can be painful in themselves. And as you get fractures, the fracture in itself causes inflammation, and that causes the nerve endings to fire off. And that in a very simplistic way, leads to the sensation of what people feel as pain.
Definitely. I mean, that's exactly what happens. And everyone knows the pain of broken bone. Most of us have broken a bone at some time in our lives. But the myeloma pain, I always describe it as somewhat different in that it's there day and night. It's sort of relentless, particularly at diagnosis, actually, when someone's got a lesion and it's breaking through their bones. It really can be quite exquisitely uncomfortable, really hard to get comfortable. No matter what you do, it doesn't get better. And really importantly, when thinking about myeloma pain, there's often no trigger to it. It's just kind of occurred out of the blue. So myeloma bone pain, how that pain presents can give the doctors a clue about is this myeloma or not. But also then it's a case of us figuring out how best to live with that pain and how to take that pain away and hopefully, get rid of it for good. That's what we're after, isn't it, really?
And, we spent some time in other pods talking about scans and how scans help us understand whether there's bone disease. So I think for this pod, we're not going to focus too much on that bit, but we were very interested to speak more about, how you manage that pain. Okay. So I think, a nice way to do that would be that if we see a newly diagnosed person with myeloma come in, we've made the diagnosis. Unfortunately, they have a few fractures in their spine. The GP has done a good job of trying to sort of get on top of a little pain initially. They're on some of these simple painkillers that we use so often, that we all use in day-to-day life, like paracetamol and maybe something like ibuprofen. But broadly speaking, what is your approach to try and say, right, pain is one of your main symptoms, let's get on top of that? Because there's a number of ways in which we can quickly understand the pain and also improve it.
Yeah, absolutely. I mean, I think I tend to dive straight in, Jam. So, really interested to hear your approach here as well. But first thing to say about pain relief and myeloma, it's often advised that non-steroidal anti-inflammatory drugs, it's abbreviated to NSAIDs. These are medications like ibuprofen, diclofenac, that you can often, naproxen, you can often buy them actually over the counter. These type of drugs, the clue's in the name, they help with inflammation as well as pain, and they can be really good for myeloma bone pain. However, there's a flag with them in terms of myeloma in that they can sometimes upset your kidneys. So generally we like to steer away from that. And I'm just putting that out there to begin with. It's not because we don't want to give our patients the drugs which really work. It's because we don't want them to then get other problems because of those side effects. However, to go back to your original question, Jam, when I see someone with pain, first I want to explore what I think the cause of it is. And if I think, for example, as you said, it's coming from a bone which is broken, I always prescribe regular paracetamol because paracetamol is a really good backbone for all pain relief. It acts as an adjunct to all painkillers, and sometimes it can act synergistically. And by that I mean, not only does it work as a painkiller in itself, but it helps the other painkillers you take alongside it work better. So it's a win-win. And as long as you don't take too much of it, so 1 gram, that tends to be 2 tablets 4 times a day maximum, it tends not to come with any side effects. So it's a win for lots of reasons. And then actually, there's this pain ladder, which has come about through the World Health Organization, is whereby you sort of gently go up on the strength of your pain relief. But I tend to say I want to start you on a Butrans patch, which is a patch that you put on your skin from the off at a very low level, which releases pain relief continually into the body, which you change every 7 days to work with that paracetamol. And the reason I do that is because I've looked after so many people with myeloma bone pain. I know that if I tweak up the ladder and go up a little bit on a pain relief, which is a bit better or a bit better, it's going to take them ages to get there. And in the meantime, they're suffering. And so actually, I tend to go straight in with a patch at a very low dose and titrate that upwards. So that tends to be my approach, actually, which might sound a bit brutal, actually. If you're going to talk to a specialist in pain relief, like a palliative care doctor, for example, they might say, hang on a minute, you're overcooking it. You don't need to go in so strong so soon. But I would say, actually, you need to go in with what works to prevent the suffering. But over to you. What do you do?
Thank you, Sally. I mean, there's a few really important things to unpick there. The first thing, paracetamol, one of the greatest drugs in the whole of medicine, unbelievably helpful across so many aspects of medical care. It's a great drug for pain relief. It's also phenomenal for fever, and we use it in so many settings to reduce the horrible impact of nasty fevers. I'm totally with you. Regular paracetamol is a must. Now, you mentioned this patch, so that's a type of morphine. So broadly speaking, there are a number of ways in which you can get morphine, one of the world's gifts for pain relief. Of course, a highly addictive drug in certain settings and of course can be abused. But when it comes to pain relief, when people are in pain, these drugs, when they are delivered and prescribed appropriately by a specialist, they're incredibly effective, they are safe, and they are not addictive. This is such a key point. So many people say, I don't want morphine because I'm going to get addicted and I'm going to become an addict. If it's done properly, the dose is modified and monitored, people don't get addicted. There are weaker types of morphine-like drugs which can be combined with paracetamol. Now, you spoke about the ladder, Sally. So some of these drugs in the middle, which so many of our listeners will have had, cocodamol, codidromol, tramadol, codeine. So two of them, the cocodamol and the codidromol, they're kind of paracetamol and codeine combinations. And those other drugs are kind of sort of morphine-like medications, which can be incredibly helpful. Sally, the example I gave to you, I think it's so interesting to hear your approach, which makes so much sense. Because honestly, if people are in pain when they come in, when they're first diagnosed, you can be telling them anything. They don't take any of it in. The key thing is they just don't want to be in pain. Okay. So we've got a number of these tools. It's key that your doctor is able to use the best one at that point. And then once you're pain-free, you can reduce down. Now, it's a different approach for, a GP, for example, where you can more gently go up the analgesic ladder, as we call it. And in some settings, Sally, I have to say, my pain is better, but I still, 20 to 30% of the time, it's not quite under control. And then I might go up a notch. A number of things to unpick there, but you've covered, the really important classes of drugs there.
Yeah, I mean, I've launched in, haven't I, with a statement which is quite contentious. And I think if you were to speak to many myeloma doctors in the UK or otherwise, they will have a different approach. Now, that is not wrong. It's all about how your doctor understands your pain, the drugs that they have available to them, and how best to utilize them. So there are definitely different approaches, but this is very much my approach. And the really important point to make here, Jam, I think, is not only if someone's suffering with pain, is it deeply unpleasant and infiltrates every aspect of their life in terms of sleep and coping, it also affects their mobility. And if you're not so mobile with myeloma, then you're going to be more sedentary, you're going to get muscle wasting, you're not going to be breathing properly if you've got a fracture in your back, for example. Yeah. And the consequences of that loss of mobility because of pain, which we have drugs to treat pain, we have these things available. But if you are not moving around so much, you are going to be more vulnerable to infections. The chemotherapy may be more of a struggle. You may feel more housebound. It may be another layer of psychological kind of impact on you and how you're coping with this new condition. So that's why I think it's so multifaceted, this pain problem, that actually just really nipping it in the bud is so important. And I just want to really bolt on to the comment you made, which is something I say time and time and time again in clinic, is the side effects with these pain relief or painkillers, particularly with morphine painkillers, like addiction, like constipation, like nausea, kick in if you're on the wrong dose. If you're on the right dose, you don't get addicted. And those side effects, if they do occur, like a bit of constipation, for example, you can manage. So it's not a case of, if you gave these painkillers, particularly the strong ones, to a healthy individual, they would notice it. Not for the right reasons, for the wrong reasons. If you give it to someone who's in pain, they notice it because it works rather than the horrible side effects, which, could exist in other situations.
You touched on two very important side effects there, Sally, nausea and constipation. They, of course, can be side effects of chemo. So we are building that into the consultation when our patients are on morphine. So for example, at the beginning, we often use in the UK thalidomide, which can be constipating. If people are in pain as well, the constipation can be quite a problem. But as you say, if we're asking about it and we're managing it, you generally can get on top of it. And as you say, the dose of the morphine might be incorrect. Other things, more often if you're on the wrong dose, is itch. Morphine-like drugs can cause an itch. And also, if you're on the wrong dose, I mean, they make you drowsy, they make you sleepy. And again, an indicator that perhaps you're on not the right type of morphine for you, because there are a number of different sort of types, can be given in different ways. You can have tablets, capsules, liquids, patches, as you mentioned. You know, the science and the art of pain relief has become so advanced, and we really have the tools to get on top of our patient's pain quickly. We must do that. Another important consideration, again, which is so crucial for myeloma, is morphine and the kidneys. Now, some types of morphine aren't excreted in the body so well if your kidneys aren't working well. And that's really important because kidneys not working well can often be a problem with our patients with myeloma. So again, if you're getting the side effects, ask your doctor, it's like, are my kidneys okay? Am I on the wrong dose for the way my kidneys are functioning? These things are all really important.
Yeah, definitely. Keeping an eye on those other parameters, which we should all be doing in clinic and working together on that. The other thing to say is myeloma is dynamic. We know that bones heal with the right treatment. And when those bones are healing, the pain relief that should be needed should be less. And so it's also really important to revisit the painkillers and to make sure actually, for example, after a number of months when the bones should have knitted back together, that you explore weaning them down and bringing them down. And that kind of gets around that long-term piece as well, and the potential of exposing somebody to those long-term risks to the kidneys, for example, or whatever else it might be. So, you know, this is a conversation which is ongoing in our clinic, which is why you and I and many doctors, I'm sure, always ask our patients, have you had any problems with pain? Which drugs are you taking? You have a look at the blood results, you explore all that in the round.
And what we often find is also people are not very good sometimes at taking the painkillers on time every few hours. The way these drugs work, they go into the body and then of course your body clears them. And if you can be a bit more regimented about how they're taken and really thinking about the time between doses, you know, that can make, you know, a really significant difference. And just to touch, Sally, on your point about weaning them down over time, perhaps after a few cycles of treatment or, you know, after a stem cell transplant, it's a great deal of pride and success for so many of our patients. They love being able to wean down that morphine because, again, for them, that is a real sign that actually, you know what, I'm getting better. My bones are healing a bit. I'm more mobile. I can do more. I need less painkiller.
Yeah, definitely. And that's kind of a real tick, isn't it, really? And I think as people go through their treatment generally, just to remove the medication just feels somewhat liberating, doesn't it? But Jam, I want to ask you a question, and I'd be really interested to hear your answer in this. I think we've got a significant number of people out there in the population don't like taking tablets. And a significant number of people, quite rightly, you and I are probably amongst them, we want to know what's going on with our body. Thank you for listening to the Myeloma Minutes podcast, proudly partnering with Myeloma UK. For more credible myeloma-related material and support, please visit the Myeloma website at myeloma.org.uk. That's myeloma.org.uk. Or call the info line on 0800 980 3332, which you can find in this episode's description. I frequently have conversations where someone says, but I don't want to take too many painkillers because I want to know what my body's doing and I want to make sure that I'm not overdoing it so that if I get more pain, I know that I can or can't do that. So actually, many people say actually living with a little bit of pain is where they would prefer to be because then they feel more in control of their condition and they know what their body's up to. So how do you tackle that? I'm sure you have those conversations as well. So yeah, what's your approach?
It's a common conversation and it's a little bit of a difficult one because when people say that, you know, just as a human that has experienced a level of pain, you kind of do get where they're coming from. At the same time, I think our body's physiologies are so good at understanding checks and balances. You know, I've very rarely seen someone do something to their body in a way that is very negative because painkillers have been masking their symptoms. And I think controlling the pain has so many more benefits because just the natural checks and balances of our physiology is, I think, very good. But it is a conversation that I do have and we talk through it because we do talk to people about listening to their bodies, right? But their point is, well, how can I listen to my body if you're masking what my body's feeling?
It's a tricky one, isn't it, really? And like I say, I think we can understand both sides of the argument, but I'm very much aligned to your approach. And also, just to reiterate the point I made about 10 minutes ago, if you are able to live with less pain or free from pain, you're going to live a more healthy life because you're able to do more. And in the round, I think that has a far, far more important impact than sort of having a little bit of pain and thinking you can or you can't do things. I know it's not that simple, but we are, for the sake of this conversation, we're somewhat simplifying this. Everyone has a very different approach to how they choose to live with their myeloma. And I think it's really important that we honour that and respect that. But it's also so important that we share our experience, I guess, isn't it?
Totally. And Sally, with the example that I gave you, there's a few other tools that we have for what we call acute or, pain that's come on, over a short period of time in the myeloma clinic. So there's two things that we should talk about, at least probably more actually, which of course are steroids and radiotherapy, which are very important tools that we have available for pain.
So steroids are used to control myeloma. We spoke about that in one of our first podcasts, didn't we? And how the pros and the cons of steroids, but what's so good about them is they're readily available. Everyone's au fait with them. We know what to do with them. And they are basically, again, anti-inflammatory. So they can calm down inflammation. And if you imagine, for example, you've broken a bone, there's going to be an awful lot of the body trying to fix that bone and inflammation going on around that break. And steroids can just help calm that down and take some of that pain away. So it's a double win, really. They're helping control the myeloma in the short term, and they're also calming down the inflammation. And therefore, it is useful, at least for the first few cycles. They tend to be included in most treatment regimens these days. So they definitely have a role. But where the myeloma treatment, in particular the steroids and the pain relief, isn't doing the job, you can consider radiotherapy. So this is radiation therapy, which is targeted at a particular part of the body where there is inflammation, and again, can take away the pain from that part of the body. What's really important to say about radiotherapy, yes, it can be highly effective. It works in about 7 out of 10 people. Still a third of people approximately may not gain benefit from it, but it's really important that you give it the right time. And I think increasingly we're understanding that effective anti-myeloma therapy with steroids, with pain relief, in lots of patients, if you give it long enough, can take away the pain. But radiotherapy can be very useful where that pain persists beyond, let's say, the first couple of months of treatment. So I think a good few years ago, we used to be much more proactive in terms of radiotherapy. We used to offer it to many more people, but arguably, perhaps we were giving it to people who didn't need it all the time. We just needed to give them a little bit longer on the right pain relief, and actually their body would sort out the pain for them. So that's kind of how I employ it in the pain setting, at least.
We're going to do a whole pod on radiotherapy because it still does have a role in certain aspects of myeloma care. But as you say, its role is diminishing. And I think that's because of the success of our myeloma drugs and how quickly they work now as well. For certain types of pain, radiation can be extremely effective. But of course, it takes planning because, Sally, the way we work, we're not experts. We have to refer to our colleagues who are called clinical oncologists. So from the point we think radiotherapy is useful, there is going to be a significant delay. They have to go and see that doctor, consent, and then they have something called a planning scan, and then the radiation is given. So that all takes time. So all these other tools are extremely important. And again, we're still on acute pain. Clearly, surgical procedures and certain types of intervention can also be highly effective for sort of focused areas of pain. And this links back to our podcast that we did with the spinal surgeon, Mr. Sean Malloy.
Definitely. And I think there's other ways you can help with bone pain. And I think we, particularly with Sean, we spoke about, didn't we, that vertebral sort of bone disease, which can be present in many, many patients. But there are, lots of other adjuncts that you can give alongside the radiotherapy as well. It's really important, actually, when you get radiotherapy, you tend to get steroids as well. So that can help too. It's knowing which approach is best for which type of pain at which time point. So it's quite a complex area, I would say.
Yeah. And I think, of course, by taking the history, speaking and really explaining how people are perceiving the pain using scans allows us to use whichever route. And it's often a combination of routes. And those targeted interventions like vertebroplasty, if someone has very specific pain around a fracture in the spine that is relatively new, it can be highly effective as opposed to giving, big doses of morphine, which don't actually target the issue. So I think really understanding what's causing the issue makes, a big difference. And Sally, if we keep on the sort of the bone theme, unfortunately with fractures, sometimes where the nerves come out, those nerves can get crushed and you get this thing called nerve root compression. So there's a whole sort of piece around the pain associated with nerves as well.
Yeah, definitely. I think the pain relief that we've spoken about so far, be that these NSAIDs, the anti-inflammatory drugs, which I mentioned earlier, we're a bit reticent about prescribing, or your paracetamol or your morphine type drugs, which we call medically opioids. They all work on the standard pain pathway because you've broken something and you've got inflammation. Nerve pain, where your nerve is being potentially, repeatedly irritated, it's being fired, giving off pain signals, is a little bit different. As you said, that can occur for lots of different reasons. It may be the nerves being squished because of the bones are pressing on the nerves as they exit the spinal column. It might be because some of the drugs that we've prescribed, actually, bortezomib or Velcade's a good example for that, or thalidomide, can cause this phenomenon of peripheral neuropathy, which we've spoken about in other podcasts. Regardless of the etiology, what's happening is the nerves are misfiring and sending pain signals to the brain. And they require a different type of painkiller approach, something that we describe as anti-neuropathic agents. So you could give standard pain relief for that type of pain, but it may not work so well. And you may be exposing someone to the side effects of that treatment without necessarily always getting the gain. So for nerve pain, which again we often explore in clinic, we might prescribe a completely different type of medication.
And again, that can, in certain situations, be surgical approaches. Like if there is a bit of bone or a disc that is pressing on a nerve, then sometimes spinal surgeons are able to sort of relieve that pressure. So there can be a physical kind of relief to that as well. But those anti-neuropathic agents, Sally, are totally crucial. In some occasions as well, you can put in sort of local anesthetic in and around these areas that are damaged, which is something that just calms the whole process down. That's called a sort of a nerve root block. And our colleagues, anaesthetists and radiologists, spinal surgeons, they all do this kind of work. So I think to people that are listening and who have pain and are struggling with pain, it's like, number one, I think we're really sorry and we don't want anyone to be in pain. But I think it's about thinking about those layers. It's like, have we really honed down what is causing my pain? And if the answer is no, then, are there specific scans that would be helpful? What is the status of my myeloma? And then once that information has been put together with how you're feeling, you look at the painkillers, like, am I taking them regularly? Am I on the right ones? Could they be changed? Am I getting side effects from, morphine? Is there a structural intervention that might help? Would anti-neuropathic agents help? At the beginning, often it's easier in a way. And sort of maybe I'm sort of transitioning the story a little bit, Sally, between sort of, acute pain and chronic pain, because often at the beginning, when there is a lot of inflammation and people haven't been exposed to many painkillers, you can go on top of the pain relatively quickly. But hopefully, within a few weeks at least.
Yeah, I mean, I certainly hope so. And we should do our best to explore that. It's like, as you say, I think the more complex area is that more chronic pain. And I think when we talk about chronic pain, what we mean is people who have been living with myeloma, diagnosed or undiagnosed, for some time. They've tried lots of pain relief and actually their body's had a chance to heal from the myeloma, but actually they're still suffering with discomfort after that. And it's much more challenging to get on top of that. And again, as you said so beautifully, Jam, loads of different reasons for that. And so important to explore, as you said, the cause, the causality, and potential interventions that have been explored and that might be useful. But this can be much more problematic. And we do refer some of our patients to pain specialists, a pain team, when we feel that we've used up our expertise in helping someone get on top of their pain and we just need somewhat different approaches. And there are many other interventions which could be considered under the right specialist. I'm thinking particularly about some creams might help for neuropathic pain, for example, not just tablets. TENS machines. Now, I don't know the evidence behind this, but the pain team will know the evidence behind this. Sometimes things which can help you sleep or physiotherapy can help, for example, with nerve root compression. So there's lots of other things you can do around the pain issue, which might lighten the load. But sometimes we do have to refer on, don't we? Because we're sort of at the limit of our knowledge.
Sally, you mentioned a TENS machine. Tell us what a TENS machine is.
So a TENS machine, as I understand it, is a small pad that you put on your body, which sends electrical signals almost to distract your body from the pain that you're experiencing. And it doesn't necessarily need to be that you're putting this pad on the area of the pain. It can be anywhere around the body. Often I think they're placed on the back, aren't they, Jam? And they just sort of send these signals just to distract the mind, really.
Yeah. So, I mean, I think there's some quite good evidence for it in pregnancy, in labour. So I think they're used, relatively often. And, some people do report use with these kinds of things. Sal, I often get asked about alternative approaches as well, such as acupuncture. Just using acupuncture as an example. I mean, some people swear by it. And as a general rule, there are very few contraindications to trying things such as acupuncture.
I agree. As long as I guess you are with an appropriate specialist, they are appropriately skilled. It is needles going into the body. This is somewhat, I say this somewhat tentatively, but slightly alternative. This isn't your standard medical model. And so if you're sitting outside your standard medical model, you've got to be careful about your practitioner. Now, please, I'm sure the majority of acupuncturists out there are absolutely more than rigorous in their approaches. When it's not directly under our care and when we're not so involved and so close to the evidence, I think we can have these discussions. It's quite hard for us to definitely recommend, however, X, Y, or Z because we just simply don't have the experience or the training in that area.
We do, as you say, lean on pain clinics sometimes. And another key speciality that we work very closely with is palliative care. So we should just delve into this a little bit. Historically, when people talk about palliative care, they're thinking about end of life, but that is really not just what palliative care doctors do. And actually now they're very much key in symptom control. And one of the symptoms they have great expertise is in pain. In an ideal world, we'd have, rapid access to palliative care colleagues, in our clinics. And for certain patients, they could sit in and we could see patients together. And certainly for a couple of years, Sally, we had funding in Oxford to get that enhanced input. And, it really made a big difference because, of course, we have to manage the majority of pain-related issues, but they do look at things in a slightly different way and have access and understanding of different approaches, which can be extremely effective. And certainly with problematic chronic pain, I still work very closely with some, wonderful palliative care colleagues.
I totally agree. And they may have access to different treatments that we can't quite get hold of. And that actually, Jan, that's where maybe they're closer to that alternative medicine, if I can call it that, the acupuncture, the Reiki, or these other interventions, which perhaps they are more familiar with referring patients towards. So I definitely agree. And I think the other thing that palliative care teams can do is just help individuals also be realistic and focus on what they want to achieve. Because some people with chronic pain, and I say this somewhat reticently, and I do think it's a great shame, but some people, myeloma or otherwise, have to learn to live with a degree of pain and incorporate that into their life. Because some of our medicines just don't fix everything in the same way we can't fix myeloma for everybody all of the time. And so I think to help people know how to live their life, if there is some background level of pain, which is just part of their condition, the palliative care team could be really, really helpful in that regard. Just other adjuncts to cope with this reality and how to manage it day to day.
I think for me, the type of chronic pain that I see that I struggle to manage and I struggle to know how to help sometimes is the chronic spinal problem. And this is so important because I think this really feeds into what we need to be preventing right at the beginning. Now, I have a patient at the moment, Sally. I've been looking after him for a number of years. He used to be a chef, but essentially because of the nature of spinal damage around the time of diagnosis, there's that type of spinal pain related to chronic spinal damage, which causes things like inability to stand for more than 30 minutes. Now, can you imagine not being able to really stand for more than 30 minutes without pain kicking in? And this all happened a number of years ago. So things like vertebroplasty don't work. There's no surgical thing. Pain relief only works up to a point because it's a very sort of situational and positional pain. And I think this really feeds into optimizing spinal care at diagnosis to minimize the impact further down the line, especially because we know that people are going to be living for so much longer.
Yeah, absolutely. And what I would say, and your case is a beautiful one actually, Jam, is actually when you've got ongoing spinal deformity, your body's always trying to compensate for that deformity. And therefore you can't use your muscles in a normal way. So they may get fatigued, they may begin to ache. So you're not necessarily dealing with the pain from a fracture. You're dealing with fatigue and muscle sort of weakness as you try and compensate for that damage that's been done and unfortunately now cannot be undone. And sometimes pain can very much tilt over into fatigue and exhaustion. And that again can be where it's very difficult, because actually no matter how much physio your patient does, no matter how much pain relief he takes, to some extent, unfortunately, he may always experience those symptoms to some degree. As we said, it's just figuring out the ways around that so that he doesn't run into trouble after 30 minutes too frequently, or he knows what to do at 30 minutes to stop it from escalating. So, lots can be bolted on around that. And again, I think that's where palliative care can really have their place.
We circled around for the last 10 minutes, essentially talking about the psychological impact as well. And this is again with chronic pain and the psychological impact and how it can feed into depression. And there's, a whole piece around really delving into how our patients are feeling psychologically, looking out for depression and treating depression if it coexists with chronic pain. And unfortunately, those things very much can coexist. And we need to work closely with other specialities because, as myeloma doctors, it's very important that we recognize the symptoms and we can talk about them to our patients initially, but then very much lean on the expertise of pain relief specialists, palliative care, psychologists, and psychiatrists as needed.
Absolutely. And this is very much a case of that multidisciplinary piece, because it does feed into so much. It feeds into your psychological well-being, how able somebody may or may not be to work, their interactions with their personal relationships, day-to-day things like going to the shop or going on holiday. It has a huge impact, as well as how they may fare with their myeloma treatment in the short term, medium term and long term. So I really think this is an area which is ripe for exploration. A big field in myeloma at the moment is frailty. It's an area of particular interest for me in particular. And I think pain can also feed into frailty. And we know that being less able to move around, being more frail can impact on your outcomes. So I really think as the treatments evolve in myeloma, and we have shared so many brilliant breakthroughs, I think, haven't we, Jam, on this podcast over the last year? But this piece needs to evolve alongside it. And I really look forward to us welcoming a palliative care specialist onto the podcast, a radiotherapy specialist onto the podcast, somebody who's an expert in frailty, a psychologist, really to delve deeper into these important areas, which we haven't really touched on as yet.
Exciting episodes, hopefully, for the next few months. And it's been great, Sal, talking about this subject. I think to our listeners, if you are in pain, do go back in when you're next in with your nurse or your doctor, delve into what you're taking, trying to understand why you're feeling the symptoms, because it's the bread and butter of a lot of what we do in clinic. But as treatments have got better, we do want to really reduce the impact of chronic pain lower down. Acute pain is something, unfortunately, that we will continue to see. But again, the impact of that will get less if we have more awareness and earlier diagnosis.
And I think it's fair to say that we in the whole myeloma community, both nationally and internationally, are all really working to drive forward this piece to make sure that people are diagnosed promptly, treated with the right drugs at the right time to get the best outcomes.
Thanks, Sal. I'm really sorry about your broken toe. We'll have live updates. This is like when David Beckham broke his toe before the 2006 World Cup, and it was like literally weekly updates. It's like, will Sally's toe be fixed in time for the summer conferences? Who knows?
It's so exciting, isn't it? Just no pictures, that's all I can say. Toes are never a thing of beauty. So yes, we'll leave that thought with you.
I hope your toe improves, Sally. Thanks for the conversation today. And thanks to everyone for listening. And I think this is the kind of episode which actually will probably get lots of feedback and people talking about different types of pain control, pain relief, the things that they've had. So please let us know what your experiences have been. We can put all those things together and come back and answer all your questions, because I think we do really appreciate all the feedback that we get. And for those emails that we do get and don't reply to, I promise we're working through them all. But thank you for the feedback and thank you for listening.
Yeah, thanks all. Look forward to speaking soon.
See you later.
This has been the Myeloma Minutes. We hope you found this week's pod engaging, interesting, and above all, understandable and genuinely useful. If you enjoyed today's episode, please follow the podcast and share it with anyone who might benefit, from your online support group, your medical team, to friends and family. And as always, if you have questions or topics you'd like us to cover in the future episodes, please do get in touch. You can find us at www.themyelomaminutes.com or email us at themyelomaminutes@gmail.com. And you can find us on social media by searching The Myeloma Minutes on Instagram and Facebook. Many thanks for listening, and we'll see you at the next one.